Good morning, good afternoon. My name is Eileen Riley. I am the Quality Improvement Manager for Cancer Programs, and I'm thrilled that you're all here today to talk about the Standards 5.8 Lung Nodes QI project. If you received an invitation to this webinar, that means you are, accepted into the QI project. We're happy to have you with us for this next year beyond, and we'll get going with some of your questions. Before we do, I want to go ahead and go over a few logistics on the next slide. So you are all muted at this point in time, but we do have that question box on the right-hand side of your screen. Go ahead and put any questions you have throughout the entire presentation in there, and we'll address as many as we can, including technical issues. So if you can't see something, if you can't hear something, go ahead and put that in the chat and we'll help you out with that. You'll also complete a post-webinar evaluation via email. Please feel free to go ahead and fill that out. And then finally, on the next slide, I'm thrilled to introduce our moderator and our panelists. And we have a little bit of a change in schedule today, but we appreciate everyone's flexibility. So Dr. Kelly Chan, who is a general surgery resident at Loyola, a clinical scholar with the ACS cancer programs, is here to help us out today and share a few resources with you all. So we'll hear from her. Dr. David Odell is running late at this point in time, so we're thrilled to be joined by Dr. Linda Martin, who is on our project team and an integral member of that team. She's also a thoracic surgeon, and I'll let her introduce herself in a moment. And then finally, Dr. Anthony Yang was unable to join us today, and so you're stuck with me, Eileen Riley, the manager of QI with Cancer Programs, and I'll do my best to kind of fill his shoes and talk about what, the QI of it all. And so with that, I'm going to hand it over to Dr. Martin, and then on the next slide, she'll review the agenda and we'll go from there.
Hi, everybody. I'm Dr. Linda Martin, and I'm the Chief of Thoracic Surgery at University of Virginia. And my involvement in this project, aside from what Eileen mentioned, is that I'm also the Society of Thoracic Surgeons representative to the Commission on Cancer, and I've been involved in development of several of the cancer standards, partly through work on the operative standards for cancer surgery, which are some terrific resources to help us learn how to raise our quality in cancer operations. I'm very thrilled to see all the interest and engagement in quality improvement in this particular area. We're going to start with reviewing the goals and timeline and what's going to happen as we launch this project. Eileen's going to talk a bit about some of the root cause tools, and then we're going to go through the rest of the agenda as you see here, writing the problem and aim statements, data collection strategies, review of resources, and then a question and answer period. Next slide, please. So the goals with this project and many of the endeavors of the Commission on Cancer are to improve the quality of cancer care and patient outcomes by, in particular in lung cancer surgery, accomplishing assessment of hilar and mediastinal lymph nodes for anyone undergoing curative intent lung cancer surgery. What that means is people whose operations are meant to remove the cancer. We're not just doing a diagnostic biopsy of, say, 1 nodule out of 50 nodules that are present. We're going to help programs figure out where they're having trouble with the standard, and then develop a standardized way for programs to monitor and assess their compliance with the standard throughout the year, and also identify ways to implement successful and sustainable solutions. And part of that will be things that the ACS and COC are going to help the teams with, and some of it I expect will be teams helping each other with this, so as we learn from each other on what's working and what's not working. And overall, we're looking to have programs achieve that greater than 80% compliance rate with the standard. However, if you're starting out at a much lower number than that, we're just looking for a 20% increase. For example, if your program is currently at 40% compliance, we're hoping to get you to 60% compliance at the end of this 2-year process. Next slide, please. So who's participating? You can see the different types of COC program designations here and how many have signed up. And again, we're very pleased to see the amount of interest. Just some initial registration data came back to give us an idea of how much experience different programs have and how much they're doing lung cancer surgery. And it ranges from 1 or 2 cases a year to greater than 150 cases a year. And you can see most of the programs are somewhere in the range of 25, probably to about 75 cases per year. Next slide. Reasons for wanting to participate in this, obviously we're preaching to the choir because you're all here, but we're looking at ways to maintain and improve compliance, collaborate with others to improve the process, really understand why the standard hasn't been met, looking at the surgical workflow, and that's everything from the surgeon's diligence with the operation, but how the specimens get processed, how they get put into reports and things, and to figure out where there might be gaps in that process, and really to enhance communication between surgeons and pathologists, which is going to be a good thing overall, learning from other programs, and then just looking at ways to collaboratively examine practice, learn best practices, apply a template checklist to ensure compliance at each applicable surgery. As part of the program, everyone has agreed to form a core QI team with at least 3 individuals, and in most cases that's going to be a surgeon champion, pathologist, and someone from the operating room team. We've got a signature of support from every physician champion and cancer committee chair. Everyone's got to attend and actively share or participate on the calls. And we want to have at least one person from the team on every call if at all possible. And then there'll also be a process of reviewing and submitting data measuring compliance with this. Next slide. Some important dates to remember. So I believe some of these have already passed. February 29th was the date that the registration was due. And this is our first group webinar here, as you can see with the red arrow. We'll be looking at developing data analysis, so we kind of all figure out where we are to start with at our own programs, and then also a process to collect data in a prospective fashion. There'll be another call in May, and then our first set of data will be due in early June. There'll be some additional group calls in July and October, and various deadlines for updates on our data on about a quarterly basis. So I think the date in May has not yet been set, and eventually we're going to break into smaller groups and form sort of collaborative groups. Still sorting out how that's going to be done, whether it's by time zone, similar size practices, things like that. Okay, next slide. And I think someone else is doing this part. Am I right about that?
You are. Hi, everyone. This is Eileen, not Dr. Yang, but I'm going to walk you through understanding the root cause of your problem. And as Dr. Yang says, this is going to take some work. So up on the next slide, please. When we say root cause, that really means the true underlying reason for the problem. And it's often not what you think it is upon first glance. And so if you advance the slide one more, applying it specifically to the standard 5.8, determining that direct cause of the breakdown. So if you're non-compliant with 5.8, there's obviously a reason for it, but I think it could be multi-factor. There could be one thing. And so really kind of digging into the root causes for these factors might help us identify that underlying cause. On the next slide, please. Understanding your root cause really requires good data. And there's 2 kinds of data we'll talk about here, but one of the things that we count as data and consider data is kind of that current state of the process. And I think lots of programs will have varying degrees of how they do 5.8. Some people might have something really solidified, a standard, a workflow, a very hard, fast, this is how we do it and who's going to touch it. And, you know, you can kind of look at your process map to understand your current state. Others might not have as robust of an infrastructure for kind of how to do the 5.8 standard. And so you might kind of, as you're going through your own current state of the process, say, you know, while it's implied that this might happen, you know, maybe we do need to document or standardize or kind of make it more official that this is kind of the process with who gets what, when, and how. So it requires collecting that reliable data of the details. This is really kind of in the weeds. And to do that, you need a data collection plan. You need that reliable baseline data and metrics, which we're going to help you get. And then you kind of need to fully develop that current state process map. So if you go ahead to the next slide, identifying key steps to kind of identifying that root cause. You've heard me say process map, and if you don't know what that means, we can talk about that, but this might be a good plug right now for our ACS QI Basics course. It's a course offered through our American College of Surgeons Learning Management System. Dr. Chan, when she speaks later, has a QR code for you to scan, and it takes you right to that course. But that course has a whole kind of section on root cause, how to do it, different tools to use. So it's a really robust way to learn about root cause and process mapping, and walks you through the steps of how to do a process map. And then, you want to think about your objectives here to identify your root cause. And so this is not something done by one person, I should say. This definitely involves your whole QI team in that at least 3 people that we're requiring for this project. It's often maybe a few more people as well. It doesn't need to involve every single person kind of involved with 5.8, but it definitely needs kind of your leaders, your stakeholders involved in 5.8 to really think about the root cause here. You want to understand the difference and know when to use data and process analysis. And again, these are the kind of 2 different approaches. So you have your data analysis, which is using data, using numbers to find the patterns, trends, and other factors. And we're going to get that in our baseline data. And as you continue to submit data over the course of the year, you're going to be able to kind of use that data to inform what you're doing is either working, maybe not working, maybe you need to change course. But then you also have your process analysis, and these are considered your lean tools. And so they break down the process to identify elements that are not value added to the process, so they're waste. So who's kind of involved that maybe shouldn't be, or where is extra steps that don't need to happen. And so really kind of being able to dig into your process map will identify both ways in which maybe there's gaps, and also where there's waste. So it's a really important step here. And like I said, we want everyone to be able to do this. It might be this very well could be kind of what we decide how we break you into smaller cohorts as well, so you can kind of connect with others who are experiencing the same cause as you are. On the next slide, getting down and dirty, the direct cause versus the root cause. And so the direct cause is kind of that initial reason, and it's often mistaken for the root cause. So perhaps, applying it to 5.8, your direct cause might be, well, the pathology report wasn't completed, or completed properly, or completed fully. And you'll say, well, that's the cause. Yes, that's the direct cause. But when we talk about root cause, we really want to get to the underlying cause of that problem. So, okay, it wasn't completed properly, but let's dig into that a little more, because just saying, hey, please complete this properly probably isn't going to get you to where you need to go. You're going to need to think about this a little further. And so if you go ahead to the next slide, I'll wrap up with some root cause tools. And like I said, Dr. Chan, when she kind of talks about resources available to you, will have a QI code or a QR code that you can scan and, kind of check out that ACS Basics course. I'll also plug the IHI. They have some really good resources related to root cause as well. I'm so sorry. So the improvements, they often fail because, as I mentioned, we solve the direct cause rather than the root cause. Go ahead to the next slide, because this is really kind of the meat of what we want to share with you today, and that's really the tools, what's available to you. We could talk about process analysis and process mapping and data all we want, but how do we make it practical, and how do we make it come to life for all of you? So there are some tools you can use, and really, it comes down to personal preference and what you feel most comfortable using and how you use it. But we have the Ishikawa, also known as the fishbone diagram, and I have a picture of that here to the right. Stakeholder brainstorm is kind of another effective tool to use when you're talking about root cause. 5 whys is a really popular one. Although I will say, before you show up in a meeting and just start, kind of chiming in with why, you're going to want to explain why you're asking, because often if you kind of keep going with the whys, you'll get to a root cause. And then finally, a failure modes and effective analysis. And we will have a discussion about that. I'm so happy to see Dr. Odell pop on here. Thanks for joining us. I was just finishing up a discussion about the root cause analysis tools. And I know you at your own organization have you've done the failure modes and effective analysis tool for 5.8. And so on the next slide, we can either keep this slide up or take them down. And Dr. Odell, if you want to share with us just kind of what the FMEA looks like.
Sure. Thanks, Eileen, and my apologies everybody for being late. Transplants apparently don't coordinate their timing with meetings, so but we can walk through this example. So as I think many of you have probably had a similar experience if you've gone through site visits or even internal audit processes and have found areas where there are deficiencies. We found actually that standard 5.8 was something that our organization had issues with. So Eileen, if you want to go to the next slide, please.
I'm so sorry, Dr.
Oh.
I don't think we have your slides in here. I'm so sorry.
Oh, sorry about that. So, you know, what we chose to do then was kind of do the deeper dive. So we looked at all of the cases that we had back over a period of time, which was 6 months. We brought together a multidisciplinary team, surgeons, pathologists, our operating room nurses, and our cancer registrars, or ODSs, and actually went through and categorized the reason that we failed to meet the standard for each of the cases. In many of those cases, there was a single factor, but in some there were more than one. And that really provided for us a working list. We identified that a component of this was actually just the education for our pathology staff about synoptic reporting for lung, because we have some pathologists who worked with our specimens who were not predominantly lung cancer pathologists. But we found actually a major component of this was education and the knowledge base for our surgeons about what the standard was. And those provided some easy opportunities for educational interventions that were quite effective in moving the needle. This will be a process analogous to what we do as a larger group, helping everybody understand how to better characterize mechanisms for non-compliance. And then in parallel, we're developing tools that can be used to address those reasons for non-compliance. And this will be the implementation part of this national QI project. So it would be fun to learn through all of this together, and you guys will have a lot of help and support as we do this. I will turn it over to Dr. Chan.
Thank you so much. And before Dr. Chan begins, I just want to mention that we will get a full slide deck, including Dr. Odell's slides, up on the project website a few business days kind of after today. So feel free to check back on that project website at this time next week, and we'll have a full slide deck there. Thanks so much.
Hi, everyone. I'll be discussing how to write problem and aim statements. Please keep in mind that active participation in this QI collaborative, we will be asking all participating programs who have either received a non-compliant rating or those who are compliant have previously completed a QI project to submit their problem and aim statements to us. And we are really looking forward to reading them. Next slide, please. So after your team has prioritized a particular problem area to focus your QI efforts, in this case, it's standard 5.8, you will need to clearly define the problem by writing a formal problem statement that concisely describes the specific issue that you are addressing. This problem statement must detail the current state of the problem, as Eileen had mentioned, and at this stage, you're not really defining your aim or your future state. Additionally, your problem statement should also avoid indicating what you think the problem is, the cause of the problem is, unless you've already performed extensive additional steps, because often what you initially think is the cause is not often the ultimate problem. And your problem statement should have a narrow scope and be patient-centered. And ideally, your problem statement should include some quantifiable impact of the problem. And it should consider the business case. What does your institution have to gain from solving this problem? In this case, it may be achieving compliance, better patient outcomes. Next slide, please. Here is a tool that you can use to help write a specific statement to help launch your project. It's the 5 W's and 1 H. So who does the problem affect or impact? When was the problem found? Where is it happening? What is happening that shouldn't be? What didn't happen that should have? And how often is the problem happening? On the next slide, I'll go through an example problem statement that So going through the 5 W's. So who is the problem affecting? Here, it's patients with lung cancer. And when did it begin? 1 year ago. Where is it happening? In the thoracic oncology department. And what's happening that shouldn't be? Patients are receiving inadequate lymphadenectomies. And what didn't happen that should have? In this case, specimens are not being confirmed by the pathologist. And how often is it happening? 2 cases a month. Next slide. Once the problem is clearly defined, your team should generate a second statement that is an explicit description of the desired outcome of a plan. That includes the target population, the level of improvement of a measurable result, and a time frame. So a name statement takes into account the following concerns. What are we trying to accomplish? Why is this important? Who is the specific target population? When will this completed? How will it be carried out? And what is our measurable goal? On the next slide, we'll go through a tool called the SMART tool, and it helps to ensure that your aim statement is complete. So first is specific. The language should be clear and concise. There should be no ambiguity as to what the aim of the project is. Next is that it should be measurable. There should be a measurable quality indicator that could be used to determine whether you have successfully achieved this aim. Later on, we'll go through a little bit of data collection. So this is something that should be measurable. And next, it should be achievable. The aim should be feasible to achieve, meaning that your institution has the necessary time and resources to make it happen. It should be relevant to your institution's needs and the specific problem areas. And lastly, the statement should be time-bound and should describe the time frame in which the aim will be achieved. It is evident when you evaluate an aim statement that if it is specific, measurable, and time-bound. However, whether it's achievable or relevant may not be very obvious from just looking at the aim statement and will require further discussion or reflection. And next slide. This is a template that can be used to help guide your aim statement along with an example statement for improving standard 5.8 compliance. So here we say it says to increase the percentage of patients receiving adequate lymphadenectomy from 50 to 80% by December 31st, 2024 for patients with lung cancer receiving curative intent pulmonary resection. Next slide. And we'll go back to Dr. Odell to talk a little bit about data collection.
All right, can you guys hear me? I'm having a little video problem, unfortunately.
We can hear you.
There we go. All right. So I know this is one of the things that is kind of front and center on the mind of most folks here. So we'll walk through a little bit about data collection. This is going to mirror very closely what the inclusion criteria are for standard 5.8. So I think many of you have probably thought about this to some degree already, but we'll talk through kind of the nuts and bolts. If we could go to the next slide, please. All right, so we're going to start with some initial data collection, and some of this will actually be helping us get to know your hospitals and the current state of resources and what you've been doing a little bit better. Part of this will actually be something that we use to help understand what steps folks have already taken so that we don't have to reinvent the wheel. And so all of the programs participating have the opportunity to learn from one another. This will take the form of a short survey on kind of the current state of your program's performance and the perceived barriers and facilitators to adherence to standard 5.8 and to doing quality improvement projects a little bit more broadly as well. This will be completed both pre and post, and particularly only pre and post data will be collected, which actually require you to go to the chart and do chart review. There will be an ongoing series of data collection questions, I should say, the total number of cases, the number of non-compliant cases, and then some occasional questions, as Dr. Chan just talked about understanding the root cause of your problems, the problem statement. And we also want to know how the quality improvement project is working for all of you. So we'll be asking you to give us some feedback from some of the events and calls that we have together to make sure that the content that we're providing for you is actually relevant and meaningful. We have ongoing data collection for chart review is a tool that we've built. We will be asking you to complete data on up to 20 patients per data collection cycle. We recognize that this may be somewhat variable based upon the number of lung cancer resections that are actually performed in each of your facilities. So it's okay if there is some variability here from site to site, but we do think it's important and valuable to get an understanding of what's going on at the patient level, as well as what's going on at the institutional level. Next slide, please. So the inclusion-exclusion criteria are those as outlined by standard 5.8. So the standard applies to all primary pulmonary resections which are performed with the intent of providing a curative operation for non-small cell lung cancer and small cell lung cancer. So this will also include neuroendocrine or carcinoid tumors. Several folks have asked that question to our group directly. And if you guys have any questions about whether or not patients are appropriate to include or not, please feel free to reach out. The standard does apply to all operative approaches. So whether this is done through a thoracotomy or thoracoscopy or robotically, all of these things apply. A couple of things that are important to consider: pulmonary resections for primary lung cancer should include lymph nodes from at least one Heidler station, named and numbered, and at least 3 distinct mediastinal stations. So this is the verbiage of standard 5.8. And the source of truth that we use is the pathology report presented in synoptic format. So for many folks, this may actually be, as we found in the root cause analysis in our program, one opportunity for improvement. As we look at the patients that do not fit under the standard, those who are undergoing resections for non-cancer diagnoses are excluded, as are those who have cancers that are primarily from a non-pulmonary site and are metastatic to the lung, as well as those resections that were not performed with curative intent. And one note about this, it's actually very common that patients may come to the operating room with a nodule that is suspicious for cancer, and have that diagnosis made in the operating room and then proceed with a definitive resection. We would consider that to be a operation for a cancer diagnosis, even if the cancer diagnosis is obtained in real time in the operating room on frozen section. I know in many thoracic surgery practices, that's somewhat standard, and we've gotten a number of questions around that. There are some questions around what non-compliance means. So the patient either did not appropriately receive lymph node staging at the time of their operation, or the documentation in the synoptic pathology report did not adequately reflect that appropriate staging care. So again, many things to unpack here. And if you have any questions, please feel free to reach out. Next slide, please. So how do we want you to submit data? We've tried to make this as easy as we can for you. There is a web-based interface that uses the RedCap software that many of you may be familiar with. This is not anything that will require you to incur any additional expenses. This will be free and provided by the ACS for you as a part of participation in this project. A link will be sent to each of your institutions through the primary contact email that we have. So in many cases, that may be one of our oncology data specialists. But if you are the primary contact of an institution and will not be the person doing the primary data collection, please be on the lookout for this email. Make sure that it gets in the hands and the inboxes of the right folks. A sample form can be found on the project website. It's a fairly intuitive thing to walk through. But again, if there are any questions, please feel free to reach out to the team. And next slide, please. All right. Now I have the pleasure of giving the mic back to Dr. Chan, who gets to talk about what's probably the most fun part of this project, which are the resources that you'll all get an opportunity to take advantage of and use for the betterment of the care of your patients. Dr. Chan.
Thank you, Dr. Odell. Next slide. There are numerous resources that are available to your program through the college, including those that are related to general quality improvement and those that are related to standard 5.8. On this first page, you'll see that there's the ACS quality framework, which is available online for free. There's a QR link that's there. You just type in a little bit of information, your name, email, and then it contains a webinar that explains how to use it, as well as a framework that can help guide you through the components of a QI project. There's also a note-taking tool, a project charter that can be referenced throughout the duration of your project, as well as tools to help implement communication and data plans. Next slide. Other general QI resources include the ACS QI Basics course, which Eileen mentioned earlier. This is purchased for $249, and it's a self-paced course that includes 6 different modules that are interactive and also contains workbook activities to help you kind of work through the QI process. Additionally, there is also a case study repository, which contains QI projects from all the ACS quality programs, not just limited COC, but also bariatrics, etc. And next slide, please. And lastly, if you haven't done so yet, please take a look at the Standard 5.8 Lung Nodes webpage, which links the Operative Standards Toolkit, as well as an updated FAQ that includes questions that were asked during our educational webinar last December. Next slide. And with that, we'll have some time for some Q&A.
Okay, thank you. Yes, we've gotten lots of questions, and so I'm just sorting through them. But one of the questions that I think Dr. Martin or Dr. Odell can weigh in on right away is what if, I think is what that's supposed to say, what if the cancer diagnosis is not suspected prior to surgery and is found during the operation? Will those cases be included or excluded from the measure?
I'm happy to field that. I think Dr. Odell even maybe addressed that in his comments, and that may have come after the question was listed. But yeah, a lot of times we go into the operating room not knowing if something's malignant or not, but we're suspicious. And so those cases, if they prove to be malignant primary lung, they do need to have the lymph nodes taken, which makes sense. You know, if the patient's coming in and they think, well, I might have lung cancer, we need to make sure that we're properly staging them so we can be certain that we're providing good quality cancer surgery and also obtaining information we need to know that may really influence decisions about additional therapies like chemotherapy, immunotherapy, radiation. So definitely they do count. And I would go so far as to say if you're doing an operation and you're not sure if it's malignant or not, but you think it might be, and you're not going to have a frozen section or you don't trust the frozen section, take the lymph nodes out anyway. It's a little bit of extra time. It's not a real risk to the patient. So if it turns out to be a granuloma, well, maybe you did more than you had to, but it's better to have that information than to feel like you have to go back and get it, and nobody's going to want to go back and get it.
Great, thank you. And this might already have been answered too, regarding exclusions, cases that undergo resection without diagnosis, undergo frozen section, deemed malignant. Where did the rest of that question go? Resected, are these cases to be excluded?
Yeah, so I think this question is actually very similar to the first one, and I would just echo what Dr. Martin just said. So the cases where a diagnosis of cancer is obtained on a frozen section should be included, and the cases where there is a high suspicion of cancer, and again, this is where there is curative intent. Many cases we may be quite suspicious but unable to actually ascertain that diagnosis until we're, we've seen final pathology, but the intent of the operation was to provide a curative oncologic procedure. Those cases should also be included.
And then if a patient has to return for further resection on the same side, does each procedure require 3+1?
I don't know if we've addressed that specific question. It's not that common, number one. So yeah, it's not that often that you're going to have done a right upper lobectomy and now you're going to come back and do a middle lobectomy or a completion pneumonectomy. That's just a fairly rare occurrence. What's maybe A little bit more of an issue is patients who've had preoperative treatment, such as neoadjuvant chemo or radiation or immune therapy. And David, correct me if I'm wrong, but I believe that those patients who receive neoadjuvant, we do not have the same requirements for the, in terms of compliance with the measure. I still think it's a good idea to take the lymph nodes out, as many as you can find, but my understanding is that those cases would not be counted for compliance.
Yeah, that's my understanding as well. And then the other comment that I would make, I think there are some situations where a patient will have a diagnostic operation followed in a staged fashion by a therapeutic operation. So, you know, if these are things that are done kind of in the same setting to treat the same cancer, whereas I think the situation Dr. Martin was talking about would be if a patient had two cancers that were deemed to be unrelated at very distinct or distant points in time from one another. In that situation, there are probably the easiest solution is to have the pathology from both of those operations combined under one synoptic operative report. So this would be the example of a patient who had a wedge resection, did not have a cancer diagnosis at the time. It was found to be a malignancy, and then came back for a completion oncologic operation, you know, within the next month or so. In that situation, it's actually perfectly acceptable to ask your pathology team to provide a summary synoptic report. Probably the more common example would be patients who have cervical mediastinoscopy done at a separate time from their definitive pulmonary resection. We can similarly combine the synoptic operative reports from those two discrete operations into one, provided that they are assessing the same cancer, you know, at the same general time point. I think it would be a different scenario if you were looking at two discrete cancers. You know, in Dr. Martin's example, a patient had a lower lobe cancer and then later on had a middle lobe cancer, or vice versa. Those patients, we would still expect each individual cancer was staged appropriately, and mediastinal lymph nodes were taken. And typically, if it's been more than a few weeks, you will still find nodes, even if they've been sampled previously.
Thank you. We're having a problem identifying who in the OR should be part of the team working on this. What OR position do you recommend to work on the study?
I can comment about what I'm doing. I've got, I think in many cases when you've got a dedicated thoracic service, you're going to have a team of nurses that are familiar with your type of surgery, so that you don't have, say, like the nurses who always do knee replacements are not typically going to be the ones doing lung resection cases. So if you've got any sort of consistency in your OR staffing, ideally to find someone who's interested in being part of the quality team. And I had no trouble finding that person, or actually persons who were interested in helping out and paying attention to things like how we collect the specimens from, you know, to the scrub nurse, how the scrub nurse then relays the information to the circulator, what they put in the computer, or how they label the specimens. That's the aspect that they'll be looking at in particular. Other things that they might do, we've got maps of lymph nodes up in our operating room. They might keep some sort of a cheat sheet in the room that you often use, or as part of your case cards or something like that. And some people even go so far as to create node collection kits. That's been shown actually to be really helpful to increase the yield of lymph node removal. If you've got a specimen cup up for each station, and they're going to sort of pester the surgeon and say, hey, you didn't get 2R, or hey, you didn't get level 7, are you going to get level 7? And they can be very important in sort of spurring everyone on to do a thorough job.
Okay, we have
the only comment I would add to that is, you know, I think Dr. Martin alluded to this. You want people who are actually interested in being involved, because those are going to be the folks who help you think creatively the most and actually make things happen. So if you're unsure who to ask, my advice would be have an open invitation. I think you're going to get those who are, you know, are really motivated and are going to contribute the most are going to raise their hands.
Okay. We have more questions, clinically focused. I'm going to take a quick break from the clinical questions and run through some admin questions for you guys real quick because I'm seeing some themes. So IRB, we submitted an IRB application. The IRB deemed it not needing to be reviewed, so I technically can't say we've been approved by the IRB. The IRB said this is not a project that we need oversight on. That letter is found on our website. I put the website to the project in the chat box. So if you do need that letter for your program, go ahead and pull that letter down. You'll be able to see how the IRB responded to us. Q&A from this webinar. Yes, we have a list of the questions you all are writing in. After this webinar, I take those questions, pair them with the responses, and then post that to our website as well. So give us a few business days to get the questions from this webinar up on the website, but we're also recording this, so you can feel free to go back and listen. Dates for data collection. Yes, I can make that more explicit. I will put a table on our project website with exactly what dates, what cases are aligned to each data collection cycle. Data collection, I appreciate there was a little bit of a discrepancy where it said the 10th at one point. We've moved it to the 30th. So the 30th of every month in which there is a data collection cycle is when it will be due. And you'll be looking at cases from the prior 3 months. So for example, in June data is due, you're gonna look at cases from March, April, and May and submit those. For baseline data here, we're looking at cases from 2023. So baseline data is due April 30th. You're going to look at your cases from 2023. We're not going to touch, January or February cases at this point in time because we want a kind of true baseline sample. Like I said, I'll write up a simple table and put that on the website so that you'll be able to kind of look and make sure you're following along with the due dates there. Somebody asked if an ODS entering the data needs access to QPort. No, REDCap is a web-based link, and so whoever the primary contact is will be the one who receives that link, and you'll receive that link at ideally the first of the month of the data collection cycle. So for example, data is due April 30th, you'll receive a link to start submitting your data April 1. I'm working my best to get that link out even earlier, so you might get it early next week. If you are the primary contact. If you need to change who you originally submitted as your primary contact, go ahead and email cancerqi@facs.org. Include your FIN so that we know which program you're referencing, along with kind of the name of who you want your primary contact to be, and we can change that for you. And then in terms of what is due, so some of you, most of you have probably received that very first data collection tool that Dr. Odell had mentioned, that survey. It's a bit like a little bit of a longer survey, but talks about kind of the barriers, facilitators, your QI. That one is due April 30th, along with the ongoing data collection and that pre-ongoing data collection questions. Those are all due on the 30th. You've received the link to the survey. If you haven't, I'll resend it all today. No need to put it in the chat that you haven't received it. I'll mass resend it today. So if you haven't completed that, you'll get a reminder in your inbox. And then, like I said, by April 1st, you'll get a link to the data collection portion of things. But there is a data collection. The form is currently on our project website as well. So if you're saying, well, I don't know what data I'm going to need, go to the project website. We have the form on there as well. So you'll be able to understand what we're looking for. The letter of support also due April 30th at the latest, although that can be uploaded via your REDCap. So you'll see there that you upload that. Let's see, and then finally, for programs that are participating who are compliant, how do we write a problem statement? So I'd love, again, to hear Dr. Martin and Dr. Odell what you think about this, but the way that we have it right now is that, yes, we'll ask what your problem statement is, but we'll also phrase it in a way to say, what's your problem statement, or what is kind of your success cause analysis? So instead of your root cause analysis, we're interested in why you are successful, what kind of resources you think you have available, what your current process is that makes it so that you have been successful. And then we'll kind of call through those responses. And then we do have another question for kind of the quote compliant programs participating. I don't like necessarily to say compliant and non-compliant, but those programs who are over that 80% or more for the 5.8, we kind of ask you, in which of these direct causes do you think you'd be able to contribute? So, you know, is it regarding the pathology and communication? Is it regarding surgeon buy-in? Where do you think you'd be able to provide the most guidance or coaching to others? And so you'll kind of select one of those. But again, Dr. Martin or Dr. Odell, I don't know if you have anything to add related to programs participating that are already, you know, doing well in this.
Yeah, I can make a couple comments, and then I'm interested in Dr. Martin's thoughts as well. I think, you know, first and foremost, from the standpoint of a problem statement, compliance is really a continual journey. You know, we all want to be as good as we can be in terms of the way that we're providing lung cancer care. So I would encourage folks to think about what they see as challenges in kind of maintaining a high level of performance, and how they look to sustain the high performance that they have. And then I really think, Eileen, you stated it very well. We really want to engage a community that's kind of cracked the code, if you will, in certain areas. You know, who's been able to get their surgeons to be, you know, real vocal champions of this? Who has been able to, you know, really get an engaged pathology department? You know, who's been able to really do things that are unique and novel, and you know, engaging the workflow and the operating room team to make this something that, you know, that works in a sustainable way, because those are exactly the process that we hope to be able to share with programs that are struggling in those areas, so that they have some models to follow, and perhaps even some friends to call on when they're really trying to figure out something that they're struggling with. So yeah, not the time to be humble. If you find something that has worked really, really well in your program, we want to hear about it and we want to celebrate it.
Let's see. So there's some questions about the letter of support. If you head to the website, there's an example of the letter, and it is to come from the CLP and the Cancer Committee chair. We just need their signatures on this kind of really straightforward letter. And then in your REDCap, you upload it to REDCap, and then that's all set. All right, a question. Facilities that only do less than 5 cases per year, is there thought from the CSSP that for facilities that cannot meet the standard compliance, that these surgeries should be performed at an institution that performs more cases, similar with standard 5.7?
I could try to answer that. I mean, that is not the point of this, to say you can't do the operations. That's not the goal behind this. And that's why I believe the cutoff is at least 1 case per year. So, you know, we're not looking to exclude programs or tell them that they shouldn't do the cases. If your team reaches that conclusion upon struggling with the compliance, or struggling to have a good understanding of how to do a good lymphadenectomy with lung cancer surgery, and it's sort of a, hey, we're really not the right team for this, that's probably a worthwhile outcome as well, to realize what people can handle and what they can't. But we haven't designed this intervention in order to be exclusionary. We're here to helpfully try to educate and help people improve. And, you know, it's very possible that hospitals that only have 1 to 5 resections a year are in remote locations where those patients might not get any treatment if they didn't go to their local hospital. And what we'd love to see is that no matter where the patient lives and what their access to care is, that they're going to be able to get good quality care no matter what. And we're here to try to help improve that quality.
Okay, great. Pathology asks every year when we review this why an EBUS sampling does not count towards the standard. Can you give a standardized response for this?
David, you want to do this, or I can re-quote what I've heard from Tim Mullett?
So the issue with EBUS is that it is very highly subsampled, and there's a much higher degree of variability in terms of the quality of samples. So the decision was made, and I will echo what Dr. Martin just said. The intent of this project is not necessarily to kind of relitigate any of the standards that are out there. but to best meet those standards as we can. So this is really about how do we attain gold standard lymph node sampling. And EBUS is a very valuable tool, but is also quite variable. And we want to make sure that that patients are getting true lymph node staging. So metasonoscopy will count if it ends up in the synoptic operative report, but EBUS does not, because it's only taking a component of lymph nodes, not the entire lymph node.
Yeah, I guess just another way to state that is when you think of what we're getting with an EBUS is we're sticking a tiny needle in a lymph node and aspirating a few cells. So it's far from anything resectional, meaning like, let's say that lymph node contained cancer and you just aspirated it, that all those cancer cells are still in the patient. And so that's important potentially in terms of the impact of the intervention. You're just identifying that it's positive. Whereas with lymph node retrieval in an operation, you're taking out huge pieces, if not entire lymph nodes or even entire lymph node basins, so that the thoroughness of the assessment is quite different. And there's also that potential for actually the benefit of resecting those cancer-bearing lymph nodes if they are indeed cancer-bearing. And another point for those of you who may not be overly familiar with EBUS, you have to be able to see the lymph nodes through the bronchoscope's ultrasound probe. And if it's under a certain size, a lot of times they're just going to be looked at and not biopsied or sampled. And so you're kind of judging it on very much of an operator dependent assessment of what that view looks like. And there's no histology, there's no analysis under the microscope to say that that lymph node is truly negative and doesn't bear any cancer cells. So there's some sensitivity, specificity, and a heck of a lot of sort of operator interpretation and variability there from one center to the next, and even from one day to the next in terms of how someone might interpret the findings of an EBUS versus actual lymph node removal.
Thank you. I have a very specific scenario. So if you cannot confirm this, we can just say that, but please confirm this scenario for inclusion. Prior wedge resection with lymph node dissection. Patient returns 3 years later with a staple line recurrence and another curative resection is performed. Is that included?
I would think so. It's several years later. We never get every lymph node out during an operation. There are always more lymph nodes. And so as far as I know that would be included. And this is where I'm pretty sure Dr. Mullet would say, this is why the compliance is set at 80%, because we know there's going to be outliers, there's going to be unusual circumstances. And so this would be a case, well, if you didn't get 3+1 on your lymph node assessment, well, that's probably reasonable. Maybe there aren't as many lymph nodes to go after as there had been before, but that's why there's a 20% leeway, and that your other more straightforward cases should account for the 80%. David, any other comments, or Kelly?
No, I would agree. As long as it's not in the setting of other metastatic disease, but if it is local recurrence only, that's a local operation that's done with curative intent.
A quick question about an INCP. If we have an INCP that all but one facility has qualifying procedures, does this disqualify us from participating and getting credit? No. So if you're in an INCP and some or most of your facilities have at least one lung resection a year, you can participate. Just those specific facilities will participate. So the one who doesn't do it, they won't participate. They'll find another project to do for the year. This project will count as one of your 2 required projects as an INCP. And this would be the kind of quote individual project. You need to find a network project that every facility, including that one that doesn't do lung resections, can participate in. But you know, you can include some of your INCPs, one of them, whatever makes sense for you, but it won't count as your network-wide project. It will only count as the individual one. Another question, would love to hear Dr. O'Dell and Dr. Martin how you might approach this. On the REDCap survey team portion, if a different team member answers differently, how do we combine those answers in one section?
Are you talking about the
So
baseline survey? or are you
Yeah, I
talking about
imagine what this
patient level?
is, we ask about barriers or facilitators and varying levels. And again, Dr. Chan, you might have a thought on this is, I think we never do this and somebody else says we always do this. How, how are we so far off base? Like, what do you recommend we do?
I mean, my recommendation is that's actually a great way to begin the conversations as your team about how you're going to approach things, because I think, it to me is a clear signal that, perhaps there are different viewpoints and resources that some folks are aware of that others may not be. And this is, I would argue, actually one of what we hope is the take home from participation in this project is that not only do you improve the quality of lung cancer care that you deliver, but you improve your capacity to do meaningful quality improvement work by learning about how to build teams, how to access resources in your institution. So, if there are discrepancies like that, my suggestion would be that you lean in, bring the team together and kind of talk about why viewpoints are different. And it may be a great way to start off the project and learning from one another internally.
Yeah, I would echo what Dr. Odell said. It makes me think of this being a great opportunity for this exercise of mirroring and active listening. That, if I have a meeting and I have a very feisty pathologist on my team here, and if he says, well, the reason we're not compliant is because you surgeons are lazy and you never take enough lymph nodes, and instead of getting defensive and arguing with him, is to maybe just hear out what his view of it is and find out what he thinks the problem is. Is it that we're continuing to take samples and calling them lymph nodes, but they're just fat, things like that, just to hear his point of view out, and then we can turn it around and say, well, we work really hard to take the lymph nodes and you guys don't label it right or whatever. But it's a chance to just sit and listen to each other's points of view, and maybe listen without judgment at first before you start getting into the back and forth, I guess you could say.
Great, agreed. Okay, well, I know we are pretty much at time. The questions are slowing, although they haven't stopped. Please continue to put in your questions or comments, but we will kind of wrap up. Dr. Odell, I don't know if you have any final words or thoughts or want to leave us with anything.
I would just simply say, it's an honor to have the opportunity to work with all of you over the next 2 years on this project, and I congratulate you guys all for kind of taking the step to join. I think this is going to be a lot of fun. I hope you do too, and we're all very excited to go on this journey together. So, thank you.
Thank you.